Drunk driving, it's not worth the penalty.
Welcome back to Mental Health Matters. We're joined today by Dr. Annelle Primm, who is the Director for Minority and National Affairs with the American Psychiatric Association. Dr. Primm has also been a practicing psychiatrist for over 22 years and is an Associate Professor of Psychiatry at Johns Hopkins. Before the break, Dr. Primm, we were really talking about the fact that there really are very few African American mental health clinicians in this country, and beginning to think about and look at what that might mean to someone who's coming in for mental health care.
That means quite a bit to a person, an African American coming for mental health care. Very often people will prefer a mental health provider who was of their same race and ethnicity and may actually have a better outcome as a result. And unfortunately, at this point, there are about 2% of psychologists are African American, 2.6% of psychiatrists are African American, and 4% of social workers. And when you compare that to the percent of African Americans in the population, there's a big gap there. So what that means is that we really need to educate people of other backgrounds to be able to better understand and communicate with individuals across cultures. This is really mandatory, and that's some of the work that my office at the American Psychiatric Association attempts to do, at least to educate psychiatrists from all backgrounds how to better interact with their patients of color, including African Americans.
Well, for the consumer, the client, the patient to feel respected, listened to, and understood is extremely important. And one of the things that we know just about people in general is that, sometimes we are distrusting of people who are different than us. The idea of training clinicians, certainly about minority mental health issues and cultural difference and all those kinds of things, I would think would be extremely important. But the question that I would ask is, you're talking about training people who many of them already have had years of training. And I would also imagine that you can kind of step lightly around our country's legacy of racial discrimination, racism, bias. Tell me about those training programs and how they might be received.
Well, an important aspect of these training programs is to get people to do some self-analysis, to really look within and assess where they are as it relates to people of other racial and ethnic backgrounds than themselves. If people are honest with themselves, they may find that they have some biases and stereotypes which can come from outside of the healthcare encounter into it, right in the smack dab in the middle of it, and have an impact on how they relate to and take care of that patient who is different from them. So we really want to make people aware of those differences and how they see people, and try to correct for them, try to rid themselves of those biases, and begin to find ways of communicating, doing role plays, that's an important part of it. How do you communicate with a person different from yourself to increase their trust level? There is a way that people can show by what they say and what they do that they care. And a patient who knows that their provider cares will do better. The relationship will be better, and we know the therapeutic relationship, that doctor-patient relationship, is really the critical ingredient, the key ingredient in getting a good outcome.
Well, one of the things that's very clear to me is that we are all affected by the society that we live in, by the culture that we live in, by this country, by the media representations and misrepresentations and all of those kinds of things. So certainly self-examination is very important. The other thing that's obvious is that we cannot train enough clinicians of color quickly enough so that this really is an issue that is going to become very important. Now, but let's also talk about some other things. I mean, that's some of the stuff that you're working on with the APA. What about some of the things that the mental health system needs to do, in your opinion, in terms of responding to the needs of people of color?
Well, I think the first thing that the system needs to do is to take a very honest look at what kind of care, the quality of care, are they providing to diverse populations. And one way to do that is to collect data by race and ethnicity, particularly data on outcomes. How are people doing in treatment? What's their level of satisfaction? What's the level of disability, or how many people, sort of achieve their treatment goals for different disorders like depression, anxiety, etc. And if that system finds that there are differences between, people of European and African, Asian, Hispanic descent, that would be sort of a wake-up call for them to figure out, okay, where are we going wrong, and what do we need to do to fix it? We really need for people to take an honest look at that and just collect that information. That's the first step. And they may choose different approaches after that to institute cultural competence training, or to identify instruments that will help them in a standardized fashion make the right diagnosis. Those are some examples.
Well, and one of the things that just struck me is just in terms of access to care. We have a system set up for the most part where people have to come in to an institution when they have a mental health need. If you think about some of the other things that are going on in terms of outreach, in terms of mobile teams, in terms of mobile treatment, in terms of taking the service to folks regardless of where they are, where they live. What about that in terms of the issue of getting to some of these populations?
I think doing that outreach or engaging people where they are, wherever they are located, is really key for diverse populations who have felt very much alienated from the system and therefore don't want to come to institutions. So I really encourage and have been fortunate enough to work myself doing that kind of outreach. It's very effective, and families of people with mental health needs really welcome you with open arms and appreciate that support. And often the outreach then opens the door to people to come to conventional sorts of services in clinics or health centers and so forth. So I think we need to invest more in the outreach if we really are serious about meeting the needs of these populations.
Well, one of the things that we know here, for instance, in Baltimore through our mental health crisis teams, is that going out to people, especially when they're in crisis and having a difficult time, and taking the service to them, especially if you can stabilize them in their home, community setting, and then link them and engage them with treatment, is that they're much more likely to participate. And it also is a way to kind of avoid institutionalization, which I would think that especially when you talk about African Americans and other minority communities is often what they see when they think about having a mental illness, think about going away to a psychiatric hospital, being locked away, being kept against your will, all of those kinds of things that are, historically accurate, but certainly don't reflect the real kind of spectrum of care that we have available to people now.
Well, that's correct, and there are it's not just a myth, It's also the reality that African Americans and other people of color experience more inpatient treatment and more involuntary inpatient treatment. And both of those things really are a turnoff for people with the mental health system. So anything that we can do to keep people, out of the hospital, in their communities, with their families and receiving care in an outpatient setting, that really is the ideal, and we should be doing whatever we can to make that happen.
Well, we can go on and on, but the other thing that I, of course, think about as well is some of the other projects that are going on in terms of training the police as another community resource. You talked about working with the clergy, but there's also a project that we have going on right now in Baltimore where we're training the police to be educated, expert responders to people, because often police are the first responders to people who are experiencing a psychiatric crisis. So, helping the police understand what to look for, what to look at, how to communicate with people.
Yes.
In ways that tend to de-escalate the crisis, we have found has been very, very effective and often helps us avoid having to use involuntary means to coerce people into treatment. So there's a lot that we can do, and it just seems to me that even in spite of all that's going on, we've got a long way to go as a system of providers, as a system of actual caregivers, and the recipients of care certainly need to be educated as well. If we can make a difference in minority populations' willingness to not only access care and reach out for care, but also know what to look for, what to accept and not to accept, we've come a long way.
Yes.
And of course, as usual, when you are a guest on our show, we are running out of time. I feel like we could go on and on and on. You're a wealth of information. As always, I continue to be grateful and impressed by all of the things that you are doing, now doing things on a national level that are making a difference. And so I really appreciate your willingness to take time out of your busy schedule to spend some time with us here on Mental Health Matters. And thank you, viewing audience. And remember, when you or someone that you know needs help with a mental health or addictions crisis, you can call Baltimore Crisis Response Incorporated 24 hours a day at 410-433-5175. Thank you, and remember, your mental health matters to us.